has been a plan to end TB as a public health goal. And we had the first end TB strategy timeline, which lapsed. And, we, of course, didn't achieve what we had planned to achieve globally. Even though TB has been known to be there for a long time, there's a vaccine that is available. There are drugs that are available and that leads to cure, but we still continue having persistent TB. In 2019, which is the latest statistics, we had 10 million new cases of TB, and out of those, 1.4 million died. And out of the 1.4 million, 208,000 were people living with HIV. Now, Kenya is considered one of the 22 most affected by TB in the world. So it's in the top 22 countries that is most affected in the world. And while in the past, we know TB had gotten controlled to some extent until the resurgence of HIV. And that's when TB cases started being seen more and more. That's in the late 80s, early 90s, where there was a HIV epidemic and a resurgence of the TB pandemic. And because of that, a lot of measures went in to try and manage TB, but most of them were measures amongst people living with HIV, where, for example, in the HIV program, any HIV infected person must be screened for TB. And so, the dynamics have changed. And what we witnessed, for example, in Kenya, the latest survey done, and there's another one which may be done soon, but the latest epidemiologic survey that was done in Kenya in 2016, one actually showed, as compared to what WHO was projecting as a cause, the number of people with TB, there was actually an underestimation when they looked at Kenya statistics alone. That epidemiology, the survey was done in Kenya. And what it showed is that there was a 40% underestimation of TB. And then it was shocking to discover that there were a lot more TB cases amongst HIV negative individuals as compared to the HIV positive. And that can be explained by the fact that HIV programs completely integrated HIV and TB and were able to manage TB, but the general public was left without anybody thinking that TB is still spreading out there in the community. It also emerged that we were having more of men than women. And then, of course, because of one, the health-seeking behavior, and then men are the ones who are out there more than women. And it also emerged that many of these people who had the TB diagnosis missed had actually visited a healthcare facility and were missed out altogether. And that has now changed how we diagnose TB, and I'll talk about that when I'm talking about the symptom screening for TB, where previously we would say that one needs to have been coughing for more than 2 weeks, and now we said anybody with a cough as one of the symptoms. You don't have to specifically specify that someone has to have been coughing for at least 2 weeks. So that's just a bit of overview on epidemiology, showing you where we are globally, and coming down to Kenya, where we see that there's actually an underestimate of the actual TB cases. There's a lot more TB in the community than we imagine. A lot of these people are coming to the facilities and we forget to screen them. So now it's a recommendation that anybody who comes into a healthcare facility, whatever else brings them to the facility, one of the things you must screen for, that's by symptom screening, is TB. So I'll just go through a few general aspects and definitions so that we are on the same page. So when we talk about tuberculous infection, this means one who has Mycobacteria TB bacilli, but there's no active infection. And by this, we call it latency. I'm sure you have heard of latent TB, and we'll talk a little bit more about that. So this is somebody who's infected by, has a Mycobacteria tubercle bacilli infection, but no active disease. And the second one is now tuberculosis disease, where we have gone beyond just infection, but now at least one or more organs is diseased. So that is tuberculosis disease as opposed to tuberculous infection. Then droplet nuclei, this is infectious respiratory particles, which are small, 5 micrometer. And because this droplet nuclei can have many mycobacteria, it's easy for one to get in. TB is easily transmissible. For example, a single cough will often have 3,000 infectious droplet nuclei. So you can see that one droplet nuclei, which is a small particle of less than 500 microliter, will have 3,000. Will have mycobacteria, bacilli, and then a single cough in itself will produce 3,000 infectious droplet nuclei. The risk of infection, some people will be exposed to the infection, but not suffer from the disease. And then the other question you'd have to ask yourself is, why is it that two people can be in a room, or a number of people can be in a room and with someone who has mycobacteria TB, and one gets infected, but others don't get infected? And there are various factors at interplay. One is the infectiousness of the case. This is the patient who is sick. How infectious are they? And infectiousness will be a factor of the number of tubercle bacilli in their droplet nuclei, for example, when they cough. And here we talk about patients who are sputum positive, whom when you measure their sputum, you take their sputum into the lab and do a microscopy as evidence smear, you're able to see a lot of a positive test. So these are patients who are more infectious, for example, than one whose sputum ZN smear is negative. And then there's a factor of closeness and duration of contact. For example, you can't compare someone who is living with someone with TB and is spending prolonged periods of time in an enclosed space than one who just comes, visits, and goes. So long durations, especially indoors and especially dark indoors, increases the risk of infection. Then there is the factor, now looking at the host, there is the immune status of the host, where if the host immune status is compromised for any reason, and there are many factors that can lead to immune compromise, one being HIV, other conditions that can cause immunocompromise, a host be immunocompromised, diabetes, malignancies, alcohol abuse, all those are things that can make a person's immune status to be compromised and increase their risk of infection, and smoking also. So transmission, usually the commonest mode of transmission is through aerosol generation, inhalation of infected droplets, which is the commonest, with the primary infection occurring in the lung. Occasionally, you may get TB entering through inoculation or ingestion. That is through the skin or through ingestion of food. That may be the primary focus of the disease, but often it is in the lungs. And usually the most infectious person is one who has pulmonary TB and lung cavities, and usually older people above the age of 12 years old, adults, of course, being the most infectious. Just a point that extrapulmonary TB is generally not infectious, but if pulmonary TB is present, because you can have extrapulmonary TB as well as pulmonary TB, in which case, then that person is infectious. So we'll now go into primary TB infection. And just as an overview, one, TB grows slowly. I'm sure you've done this in microbiology. It divides every 25 to 32 hours within the macrophage. And it takes about 2 to 12 weeks for cellular immune response to develop. And one of the markers of a cellular immune response developing is a positive tuberculin skin test. And just as an overview, usually at around 2 to 4 weeks after infection, there'll be cell-mediated immune responses. Usually two types of cell-mediated immune responses are at play. first is a delayed type hypersensitivity reaction. And this is the immediate reaction, which leads to destruction of activated macrophages which contain bacilli. And it also results in tissue necrosis and caseation. And then there is the cell-mediated immunity, which results in macrophages being activated. And the macrophages are activated into epithelioid cells, which now leads to the formation of a granuloma at the periphery of this caseation that occurs with the delayed type hypersensitivity reaction that now starts destroying all the cells that are infected. Usually spread of TB is by the lymphatics. So the hilum, the cervical, the abdominal, and the blood is the most common mode of spread of TB. So that was just an overview, and just to show you what exactly I was talking about. So like we said, the most common form of infection is infectious bacilli, which are inhaled as droplets. And once the inhalation occurs, then the bacilli go into the airway and go into the alveolar, affect the alveolar macrophages, and that's where the mycobacteria are. Then once the macrophages are infected, first we talked about the immediate delayed hypersensitivity reaction that immediately starts destruction of infected macrophages. But with this is production of cytokines, and these cytokines attract more macrophages to the site, and that's how the granuloma forms. And this is how our bodies are able to contain the mycobacteria. Through the initial infection of macrophages, an alert is sent, cytokines are produced, and this leads to accumulation of more epithelioid cells. And as you can see, this is the granuloma with the infected macrophages in the middle and the surrounding cells all around. And as the destruction of these infected macrophages continues, necrosis starts to occur in the middle, and that's why granulomas will often have a necrotic middle. So that is and then there's of course the fibrous scarf surrounding it as a way of trying to control the infection. Now, in most cases, the infection is completely controlled, but there are cases where the infection may progress, and I'll talk about that. And this, for example, with co-infection with HIV. And as you can see here, what will happen is then the immunity is unable to contain the infection, and the mycobacteria are released out of the granuloma, which does not hold the mycobacteria. So that was an overview to just explain to you how these happen. So the first, after first exposure, during inhalation, as we've showed in that diagram, the bacilli lodge in the terminal alveoli, and these are phagocytosed by the macrophages, as we've talked. And the first reaction is a local immune response, which is what we call agon focus. And agon focus is usually a very small subpleural lesion. So this one, and it will often be just subpleural, below the pleural at any point. Often you will find it on the upper part of the lower lobe. So where you have, for example, if this is the lower lobe on either side, you'll find it at the upper part of the lower lobe, and often subpleural. And it usually, once it forms, there's rapid transportation of the bacilli to the regional lymph nodes. So often here. So for example, if the agon focus was around here, remember it will be subpleural, there's then rapid transportation of the bacilli to the draining lymph nodes, the hilar lymph nodes most often. And that's what now forms the primary complex, which consists of the agon focus, the lymphatics that are draining, and then the lymph nodes to which the bacilli were transported. So that is now the primary complex, which is then eventually, as the body controls it, it's then replaced by a fibrous scar tissue, which may have calcification. And this is in the case of an intact immune system where the body then controls it completely, and the person then just had infection but did not develop the disease. And this is just now an overview to show you the same. So there's the initial inhalation of the mycobacteria, goes into the lung. You have the primary lesion, which may then drain to the draining lymph nodes. In 90% of the cases, 90 to 95% of the infected individuals completely recover. Yeah, and then we have a small proportion, 5 to 10% of infected individuals who may progress right away to cavitary TB disease. And then we have this group, 90 to 95% of infected individuals who recover, and these are the ones we say were latently infected, TB. They got infected and the body was able to contain it, and most of the time, unless you do a tuberculin skin test and or an interferon gamma assay, which I'll talk about later, you will not know that this person was infected, and they are not infectious. But there are cases in which then these people, the disease may become reactivated. And this reactivation of latent disease may occur, for example, in cases of immunosuppression, which I've talked about. And then now they join the path of the 5 to 10% of individuals who have progressed to cavitary disease. Now, I must point out that even though 90 to 95% of infected individuals recover, they are actually most of TB in the world has been seen to be found to come from people who are latently infected by TB when they get reactivated. This proportion of individuals, the 5 to 10% who progress to cavitary disease, are very few. So the majority of TB is from people who are latently infected and later had reactivation of the disease. And when we look at the global statistics, we see that about a third of the world population is latently infected with TB, and they form the majority of the pool of people who are transmitting TB. So primary TB infection may also present through hypersensitivity reactions, not just in the chest. And I just thought to point out that, where you may just see it's a positive tuberculin skin test as a form of hypersensitivity reaction, which we have said is, one of the initial cell-mediated immune responses, delayed type hypersensitivity reaction that we are able to see at 2 to 4 weeks. A few people may have erythema nodosum. Some may have conjunctivitis, as you can see here, and then a few dactylitis and polyarthritis. So those are other hypersensitivity reactions that may occur in primary TB infection. So as a summary of primary TB infection, what we have said is that the usual outcome is most people who get primary TB infection, in 90% of cases, they recover with no clinical disease. You can only tell they were infected through a positive tuberculin skin test or a positive interferon gamma assay. These are said to be latently infected, and globally they form around a third to a quarter of the population, given the statistics that are out there. Now for pulmonary, which is what we are discussing today, so the pulmonary outcome may be the primary complex, which we have talked about, or progression to where there is complication from a complex, where there is advancement to pneumonia, where you have, for example, bronchial compression leading to lobar collapse. It may even progress to pleural or pericardial effusion. Some may progress to disseminated disease, and this you often see with immunosuppressed patients, where you have lymph node enlargement, meningitis, miliary disease. And then, of course, there are hypersensitivity reactions, which we have talked about. So primary infection can have any of these outcomes, but as we have seen, majority of the patients fall under those who remain latently infected, and these are 90% of the people who get primary infection. And these 90% of the people form like a third to a quarter of the global population of people who have latent TB and who are responsible for the majority of TB globally. And they contribute to these when they get reactivation of the disease, when now the immunity is suppressed. And so the latent TB, which was well controlled, now becomes active. That said, even someone with latent TB infection can get a secondary TB infection. Then we've talked about the 5 to 10% of people who, from the primary infection, rapidly progress to active TB disease. And this is often the immunocompromised people and children. So what are the risks of developing active TB? Because we've said 90% of the people, recover. Normally, we'll see, like, with normal immunity, only 10% of people will develop active TB, and the risk is that's 5 to 10%, as we have demonstrated in the previous slide. So going by the higher proportion, with normal, only 10% of people with normal immunity will often progress to active TB, because 90% of people with normal immunity will recover without anybody knowing that they had TB. The risk of progression is in the first 2 years after infection, then later in life. Then the highest risk is amongst children who are less than 5 years and the elderly. But in the cases of decreased immunity, for example, people living with HIV, 50 to 60% of them rapidly progress to active TB disease. And if I'll go back a little bit, they are amongst these ones. So with most being 90%, if our primary infection pool of patients is immunosuppressed patients, then we will have a 50-50 distribution. But if it's just the general population, then 90 will recover, 10 will progress to primary TB disease. So I hope that's clear. So looking now at the post-primary TB and secondary TB, where just as a bit of explanation, post-primary is where we are saying someone gets the primary TB disease and it doesn't go back into latency, but progresses right away into active TB disease. And then there is the secondary TB disease. So these are people who've gotten reinfected. They had gotten the initial primary TB disease, they had recovered, and now they get TB again. Usually this can happen in various means. It can be a reactivation, which we have talked about. Someone with latent TB had gotten it years back. Then maybe the immune system gets weakened and the latent TB becomes reactivated to contribute to active TB. And as we have said, these are the ones who contribute to the majority of the people who have TB. Then there are people who get reinfected. You had latent TB before, you remained asymptomatic, you have been okay, but now it's not a reactivation of the already existing latent TB, it's a reinfection, a new infection. Yeah, and for these cases, it may be pulmonary TB, which happens in 30% of the people, or extrapulmonary TB, with extrapulmonary being more amongst the immunocompromised. So what are the factors that increase the likelihood of TB? We've mentioned a few of them as we are going along, but anything that causes immunosuppression, the commonest in our setup being HIV infection. But there are other factors that can cause immunosuppression. For example, being diabetic is a risk factor. Malignancies, one who's undergoing chemotherapy, smokers, people who take alcohol, all those are factors that excessively, of course, all those are factors which can increase the likelihood of getting TB. Having a positive protein derivative, that's a positive TST or an IGRA test result, then this already confirms one is infected with latent TB, and they're at risk of progressing to active TB, for example, if they get immune suppressed. Then anybody who's had a prior history of TB treatment is always at higher risk of reinfection. Of course, TB exposure increases the likelihood of developing TB. Then travelers, for example, travelers who now come to an area of TB endemicity, they are at a higher likelihood of getting TB. And then, of course, homelessness, people who dwell in shelters, incarceration, because of, there is no proper circulation, infection control. So in terms of presentation, there's the classic presentation associated with active pulmonary TB, and that is cough. Previously, we'd say any cough of more than 2 weeks. Now what we say is any cough warrants investigation for TB. As I've told you from the survey that was done in 2016 in Kenya, what we saw is that, people had presented, some of the people had presented to the healthcare facility complaining of a cough, and that was dismissed purely based on the duration. So what we say now is anyone who visits a healthcare facility and has a cough needs to be investigated further for TB. Of course, there's the clinical assessment in trying to aid in making a diagnosis of TB that should not be overlooked. So not to say that you should rush into the expensive test first. Then there is weight loss and anorexia. Often patients with TB lose appetite very early and start losing weight rapidly. So whenever someone tells you that they've rapidly lost weight, you should actively seek out to investigate for TB. Fever, sweating at night, sometimes even when it's cold, a cough with production of blood, hemoptysis, and then chest pain, and then unusual fatigue that cannot be explained. All those are some of the symptoms of the clinical features of active pulmonary TB. And then there are various differential diagnoses, and this list is by no way exhaustive, and these are some of them, and I've not ordered them in order of importance, just alphabetically. But these are some of the things you should look out into when you're looking at differential diagnosis of TB. Not to forget COVID pneumonia, which we now know, and sorry, I've not put it there. But with COVID, we may focus so much on COVID that we actually miss out TB even when it's there. And already when one has TB, then their lungs are vulnerable, so they are more likely to get COVID pneumonia, and we can easily get misled and just focus on the COVID pneumonia and forget the others. So actinomycosis, aspergillosis, bronchiectasis, constrictive pericarditis can mimic fungal or other bacterial pneumonia, can also be differential diagnosis. Histoplasmosis, a lung abscess, which may also be caused by Mycobacteria bacilli, but also other bacteria that cause abscesses. Then nocardiosis, and then non-small cell lung cancer. So that's not an exhaustive list. There are other differentials that you should also look out for, but I just picked like some of the most common that you may need to immediately look into. And how do we make a diagnosis? Of course, the simplest and most easily available. First, remember your clinical acumen, clinical assessment, history taking, and physical examination will often guide you to suspect TB from the onset, even before you go into the lab diagnosis. So always remember to take a proper history, and then the physical examination and a proper chest examination, which I know you're doing in your clinical rotation. So not to rush into just the lab diagnosis, but always remember that is the first port of call to help you in knowing what the differentials will be based on the symptoms and then your clinical findings. So there are various diagnostic tools. First is the smear, which is just requires sputum, at least 3 samples collected within the same week, and an early morning sample, which is preferable. And what one looks at is the stained Mycobacteria tuberculosis bacilli using a light or fluorescent microscope. And here I have a picture of what the bacilli look at. So the one on the left, what I'm pointing at is what you see on light microscopy, and the red are the bacilli, and then there's the fluorescent microscopy, you can see the yellow. And then there's the culture, which we know is our gold standard, which can be gold, solid or liquid. And then there's a line probe assay, which is polymerase chain reaction based, helps to identify DNA specific to MTB, and is very useful in helping us in RIF and isoniazid susceptibility, and helping in ruling out multi-drug resistance. And then there is the expert MTB RIF, which usually tells you about rifampicin susceptibility as opposed to the line probe assay, which tells you both. So it's also an automated PCR. It's able to detect MTB and rifampicin susceptibility, and this is just a picture to show you. This is now very widely available in most places, and should be embraced, because then one is able to tell whether one has drug susceptible TB or not from early on with a quick turnaround time. So I thought we just demonstrate to you that is the Ministry of Health Gene Expert algorithm, how to use the Gene Expert. So what we say is anybody who is presumed to have TB, for example, you have taken your history, physical examination, and you highly suspect this person has TB, Gene Expert is one of the tests you should order, course together with a chest X-ray. And once you do the Gene Expert test, these are the various ways of interpreting. And I'll just go through. For example, if you have a positive, if the result says MTB is positive, and there's a RIF, the R is the RIF resistance, the other R is resistance, so RIF resistance. So these are a patient whom then you're thinking they have drug resistant TB. And so if you think they are already having factors that make them get classified as high risk for drug resistant TB, for example, in HIV, then it's important that you collect a sample for line probe assay to help you with getting whether there's also isoniazid resistance. Remember, Gene Expert only tells you about rifampicin. And then you also need a culture, which will help you in knowing first and second line drug sensitivity test. But you shouldn't wait for the line probe assay and the culture. You should immediately start the MDR treatment, which then once you get the results of the DST, then you can again adjust the regimen. Those who are classified as low risk, for example, just an ordinary person, no risk at all for TB, but you do a test and you realize it comes out as RIF resistance. So in this case, you need to collect a second sample to just confirm that the Gene Expert is actually accurately reported as RIF resistance, because there's a possibility of also a false positive. So once you confirm that there's actually RIF resistance from the second test, then you follow the same method as the one for high risk. And if the second test shows that MTB is positive, but there is sensitivity, then you start the normal regimen. So in cases where you get an MTB positive and rifampicin is sensitive, again, you classify as either high risk or low risk for drug-resistant TB. For high risk for drug-resistant TB, you collect a sample for line probe assay and culture, but you start on treatment for drug-susceptible TB as you wait for these results. Then management will depend on the results. And if there's low risk, then you just start them treatment for drug-susceptible TB. Then anyone who has an indeterminate result, it's always best to collect another sample and repeat. For those who are negative and they don't have anything that will make you suspect that this was a false negative, then you manage for, you now go through your differentials and manage appropriately. And of course, closely follow up and be open to repeating later if there is need. So that's just a slide to tell you what high risk is and what low risk. High risk for drug-resistant TB is and what the low risk categories are. And we've gone through a bit. So anyone who's previously been treated for TB, has had a contact with someone with drug-resistant TB, any TB patients with a positive smear result at 2 months or 5 months of treatment, any patient who develops TB while on isoniazid prophylaxis, healthcare workers, prisoners, refugees, all those are classified as high risk for drug-resistant TB. Then low risk are, for example, all presumptive TB cases who are not in the high risk category. So anybody who's not in the high risk category, even if they are people living with HIV, children below 5 years, all presumptive TB cases with a negative result. So those are low risk. And this is just a key to tell you what samples you can collect for sputum, literally any sample, sputum, CSF, gastric aspirate, nasopharyngeal aspirate, pleural fluid, pericardial fluid, ascitic fluid, a fine needle aspirate, and lymph node biopsy. So you can collect all these specimens for a gene expert, so you should not feel limited. Just a summary of the various methods and what are the advantages, the strengths and weaknesses. And these are things I've mentioned as we are going along. So for smear microscopy, again, you can collect just about any specimen. Usually, often it's sputum and gastric aspirates that we collect. It's cheap, it's readily available, but it has very low sensitivity. The turnaround time is 24 hours, which is good. And with HIV, unfortunately, we have more smear negative, so it may not be so advantageous in those cases. Culture, you can collect any specimen. It is the gold standard with very high sensitivity of 80 to 85%. However, it's expensive and takes time, 2 to 4 weeks to get the result. So of course, you can't use it for immediate decision on treatment, which is why, for example, on that gene expert algorithm, we have classified and showed you how to treat. And there is the line probe assay, which we've said it helps in making a diagnosis to see whether there is both isoniazid and rifampicin resistance. So very good with already sputum positive or a culture isolate of MTB, because then it will be able to tell you the resistance, but it will also detect TB and multi-drug resistant TB. It is expensive, it is lab-based, not often used, and it can't be used as an initial diagnosis. So, and it takes about 2 days. Best with a positive sputum. Then there's the experts. These we have gone through in detail, and there's some slight reduction in sensitivity with HIV positive individuals. Hi, sorry, I apologize. I think I got disconnected. I lost those blackout where I was, so I'm not sure how far I left you. Maybe someone can unmute and then let me know so that I go back to the point I was. Can you hear me?
Yes, we can. You're on this slide.
Oh, this is where I was, so I didn't lose you that much. So I apologize. There's a blackout and the internet I was using then got disconnected. So let's just proceed. I apologize for that. Okay, you can see clearly?
Yes, we can.
Okay, so yeah, in case there's a problem, just say. So for the chest x-ray, these are the various changes you can see. Hilar lymphadenopathy, parenchymal changes, pleural effusion, and it has the advantage of a short turnaround time. However, it requires experience and skill to be able to interpret it. Then there are immunological diagnostic tests that can be used as adjuvants to support. There's the tuberculin skin test. Disadvantage is that it doesn't distinguish between a positive test due to vaccination and disease, and it's usually negative in patients with advanced HIV disease. Then there is the quantiferon or TB, which helps to detect interferon. It has the advantage compared to the TST in that it does not distinguish active from latent TB, but it's not affected by the BCG vaccine. It also doesn't predict the risk of progression. For example, if it's latent TB, and it cannot differentiate reinfection from reactivation. So these are just tests that can be used as adjuvants to help make a diagnosis when you're having a hard time making a diagnosis. So as part of other approaches. How useful are the various tests? So for chest x-ray, again, we cannot use it as a standalone. You use it with all the other tests to aid you in making a diagnosis. It's not specific. Hilar lymphadenopathy may be useful in guiding you. Lateral may not be too useful. A wide-end mediastinum may help you in making a diagnosis. Other things you may see is compression of the airways, opacification, millet-sized lesions, which will help you make a diagnosis of miliary TB. Then pleural effusion, cavitatory lesions, mostly amongst those above 12 years of age. And then remember, it may be normal, for example, in cases of extrapulmonary TB. So very useful, but not as a standalone, combined with your clinical acumen and other investigations where feasible. So going into treatment, I'll first start with latent TB infection, which we have talked about. As we have said, it's the one which contributes to the most cases of TB, as in most active cases of TBs are actually a progression of latent TB infection. So it warrants mention because we then need, if we treated those who are at highest risk of progressing to active TB, then we might be able to control TB. And it's for this reason that now there is categorization of the people who should be treated for latent TB. And this is just as an overview of what we use. So previously we'd use isoniazid for 6 months. Now we are using rifampicin and isoniazid once weekly for 3 months for anyone above 15 years old, and this for both HIV negative and HIV positive. These are the advantage in that it's once weekly for 3 months, unlike isoniazid, which is daily. But of course, with the weekly, there's also possibility of forgetting the weekly dose, but it's definitely easier than daily. Then for those less than 15 years old, it's rifampicin and isoniazid daily for 3 months as opposed to 6 months. And this for HIV negative children and adolescents less than 15. Then for HIV positive children, so you can see then now here we use isoniazid daily for 6 months, and this is also used for pregnant women and those who can't tolerate rifampicin isoniazid or rifampicin rifampicin. So there is minimum requirement for TB treatment for susceptible or drug-resistant TB. So one is that you must have at least 4 new drugs with some probable efficacy. 2 of these drugs in the 4-drug regimen have to be core drugs. one with bactericidal activity and one with good sterilizing activity. And these two, one bactericidal and one sterilizing, have to go all along the treatment, 6 months if it is drug susceptible TB. Then the other two drugs of the four are accompanying drugs, which are protecting the action of the core drugs. And they are not necessary to continue after the culture conversion or sputum conversion. So we need enough time for cure and avoid relapses. So you need drugs with good sterilizing activity. For example, rifampicin, pyrazinamide, and moxifloxacin, which have good sterilizing activity. And these, they can reduce the time of treatment. So as you can see, rifampicin has very good sterilizing activity. And so it goes through the treatment with isoniazid having very good bactericidal activity, which is why they are the two drugs which go on. So again, this is just to show you the various strengths of the various drugs, which ones have good bactericidal activity, which ones have sterilizing activity, with the strongest bactericidal activity being isoniazid and rifampicin, and the strongest sterilizing activity, again, being rifampicin and pyrozinamide. Then in terms of prevention of resistance, of course, you combine rifampicin, isoniazid with their bactericidal and sterilizing activity, and then ethambutol, with the lowest being pyrazinamide. And for bactericidal, the lowest bactericidal being ethionamide and pyrazinamide. Then there's the various toxicity, which I'm sure you have done in pharmacology, with the lowest toxicity being ethambutol, rifampicin, isoniazid, fluoroquinolone, and the highest being the drugs we use for multi-drug resistant TB. So then there's the rational classification of drugs. I think these you can read in the interest of time. So there's the first line drugs that we use for drug susceptible TB, HRZE. And then there's group 2, which are some core drugs, as we have said. There's the core drugs, quinolones, injectables, other second line drugs, which you'll go through, and then there are other reinforcement drugs, the linezolide, bidequilin. Then these are the guidelines of how we treat TB. So for pulmonary TB and extrapulmonary TB, apart from bone and TB meningitis, we give 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol. And then after the 2 months or following sputum or culture conversion, we then drop the non-core drugs and continue with the rifampicin and isoniazid because of their sterilizing and bactericidal activity, respectively. So for extrapulmonary TB, specifically bone TB and TB meningitis, that's where we go on for 12 months. Again, 2 months of RHZE and 10 months of RH. So all TB apart from bone and meningitis, we go for 6 months and then double the period for bone and TB, with the intensive phase being 2 months for both. For MDR treatment, again, you can go and read a bit about this. So there are 2 phases of treatment, the same, an intensive phase where there's use of injectable drugs, and this phase is 4 to 6 months, again, based on the monitoring. And I think this is something you can go and read as you advance. And then there's the continuation phase of 5 months, where they continue with 4 drugs oral. So in the intensive phase, there is high dose isoniazid, ethambutol, pyrazinamide, moxifloxacin, and injection with kanamycin or amikacin, prothionamide, and clofazimine daily. And the duration, the reason we are saying 4 to 6 months, it's because the duration will be guided by culture conversion, but it should not be continued for, it should be continued for a minimum of 4 months. It can be extended for maximum of 6 months. So it can be there in between 4 to 6 months. Then there's the 5 months, and you cannot extend the continuation phase. So thanks. That's the overview of pulmonary TB and how to manage. I think we just have a few minutes. If we have any questions, we can do so in the remaining few minutes. Okay, so any questions? So I can see one question here, two actually. So one, is it a must to treat latent TB? If not, then in which cases should we treat latent TB? That's a good question. And then the next one is, what is the difference between PPD and TST? So those are good questions. I did not extensively cover latent TB because it was not what was to be covered, but I thought to just point it out. So there are guidelines which we have and on who to treat for latent TB. And often you treat people who are at high risk of progressing to active TB. And that is really because it's as a public health approach. If it was possible, anybody with latent TB should actually be treated. And now we are moving to that point where we are saying anybody with latent TB, but you also have to remember that it's challenging and resource constraining to confirm latent, that a person has latent TB. So for now, the practice is people who are at high risk of progression to active TB. For example, all persons living with HIV need to be treated for latent TB. And for these persons living with HIV, we don't normally have to do a test to confirm latency because you'd have to either do a tuberculin skin test, which is maybe negative or may be false positive because most of the people are vaccinated with MAN2, or an interferon gamma release assay, which is quite expensive. So for people living with HIV, what is recommended is you do a symptom screening to rule out active TB. And once you have ruled out active TB, then you confirm that they are latently infected with TB. Then you treat them. The other category is anybody who has had exposure to a sputum positive case of TB. So those are people who are eligible to be treated for latent TB. So children, I think you will do that when you're doing pediatrics because then there is the categorization of below 1 year or above 1 year. But what I can tell you is that any child below 1 year who has been exposed to a sputum positive TB case needs to be treated for latent TB. Any child above 1 year who is living with HIV should be treated for latent TB, whether or not they've been exposed. Then what is the difference between the tuberculin skin test and purified protein derivative? So the purified protein derivative is the derivative that is used to do the tuberculin skin test. Then is the MAN2 test going to be positive in vaccinated people? Yes, often it is positive, which is why we say it is not too specific, because when you get a positive test, it doesn't necessarily mean that it could be positive because of the Bcg vaccine, because of the components that have been used to make the purified protein derivative, which is different from interferon gamma release assay, which in that case, then you can use interferon gamma release assay is not affected by the vaccine. Then do we stop injectable after 6 months, even if their culture is still positive? So yes, as per the guidelines, it's you confirm whether there is culture conversion. So we say the duration is 4 to 6 months, not recommended to continue before 6 months. But then these were multidisciplinary team members discussed. And because of the toxicity of the injectable drugs, that's why it's not good to use them for prolonged periods of time. But these cases are discussed now on a case-by-case basis. But if you're out there, then the recommendation is at least stop for at 6 months, continue with the oral, but continue monitoring for culture conversion. Why early morning sputum specimen taken? So early morning first before they eat anything, and then we expect that in the morning is when most people are able to produce the sputum because they've been resting and their secretions have accumulated. So you're more likely to get a better yield at that time. Okay. Why are ARVs stopped during induction phase during treatment of TB? So that is not accurate. ARVs are not stopped during induction phase during TB treatment. So what happens is if you get someone who is both newly diagnosed with TB and HIV, then you start TB treatment, and then you lag and start the ARVs later. And this is because of the immune reconstitution syndrome that is likely to happen, where once you start ARVs, the immunity kicks in, and if there was an underlying infection that was not detected, usually TB and cryptococcal meningitis, then there's likely to be a flare up and a deterioration. So what we say is treat the TB initially and the cryptococcal disease, and then after they've taken the drugs for some time and there are defined periods for that, then you can start ARVs. But when you get someone who was already on ARVs, you don't stop, you continue. Will giving booster BCG vaccines help in lessening progression of latent TB to active? No, because remember, with latent TB, someone is already vaccinated, is already infected. The BCG vaccine, the whole idea of a vaccine is to prevent the infection from setting in the first place, especially the BCG vaccine. But when latent TB is already there, it means someone already has the MTB in them, just that it's in a quiescent state, contained by the immunity. So you give treatment to cure, which is why you give isoniazid, rifampicin, rifampicin, as I have demonstrated, to clear the mycobacteria that is already in the body in latency, but not a vaccine. Yeah. So that is, does taking BCG vaccine mean you won't get infections if taken at birth? No. So the BCG vaccine has been there for decades, and what has been shown is that it protects us from severe forms of the infection, but not from the primary infection. So you can get the infection, and that's why most people will go into latency. Of course, the vaccine as well as our immune system. But, and we do give BCG vaccine at birth from years back. That has been the standard. But it's been shown to protect people only from severe forms of the infection, but not the infection itself. So there's a lot of work going on into vaccine discovery to see if there are other better vaccines that can be discovered that will prevent one from getting infections, but the BCG vaccine has not been able to do that. Okay. All right, I see you've said thank you. So I assume there are no more questions. Thank you for your active participation.
Thank you for your time, Dr. Njagi.
All right.
Will Dr. Mecha be joining the same class?
Let me confirm with him. Probably just hold on. I'll not log on.